First question, did I promise you too much? I'm really overwhelmed. This is really, for me, years in anal incontinency, it's tremendous. To do this in half an hour, to explain me so many things, I'm so thankful. I now invite Professor Schlumpf and Dr. Dindo, two surgeons. I have to admit that Mark Fox is in the audience. He understands much more about this, but he was sold out. They stole him from my podium, but I have some very good two surgeons. Dr. Dindo does for me the sacral neuromodulation. Even so, I have to say, in 1995, I did that on my own as a non-surgeon, but that was stolen by Matzel and the group to the surgeon. But I'm very happy now to hear from you what kind of questions you have, and from the surgeons, what shall we do? Be internists. Please.
So thank you very much for this very interesting talk. As a surgeon, sometimes I'm a little bit puzzled. You have shown a whole bunch of tests that we can do, but sometimes I do not know how can we translate the results of the tests into treatment. For example, for sacral nerve stimulation, we still follow the trial and error method. So just do it, and then you'll see whether it works or not. Since we do not have positive or negative predictive factors. So sometimes I don't know what kinds of tests do I have to do? Is a manometry really important when I see that with my finger that the sphincter is weak? Does that really change my decision to find the real treatment or the best treatment?
So two ways to respond to your question. By the way, great question. So one is trying to apply a treatment like SNS and then trying to find the mechanism, which is how it's been done. And though people looked at sphincter pressures, it didn't change. People looked at rectal sensation. Initially, people said, oh, it's making them more sensitive, but then other studies said it didn't. People said, oh, it's improving the compliance. It didn't change. And then work from Australia said, oh, if you do SNS, it actually impedes the flow of stool. It increases retrograde movement of stool. So I think we have to stop that approach. We have to do it a little bit more like what I've been trying to do, which I just showed with you. So as we were developing this technology, we were trying to see mechanistically at the same time, what is this technology doing or not doing? If it's not doing, well, let's be honest and say, well, it doesn't. Maybe it helps the symptoms. I don't know how it works. And that's where we are with the SNS. SNS, you're right. It helps many people. We have zero clue how it works. And that is why your sphincter examination is just going to be as good as doing intraoral manometry. So we will never be able to predict what it is. But looking at the other part of your question, where the tests help is really, fecal incontinence is like a jigsaw puzzle with multiple things happening. Ultimately, the presenting feature is stool leakage. What we're trying to really dissect out is the mechanism, because maybe then we can see which components are critical in our treatment approach, and also to tailor our management appropriately. Whether it is biofeedback, maybe combining maybe someone with a large sphincter defect, younger patient, it seems very reasonable to do sphincteroplasty, but sphincteroplasty itself may not help them, because if they have neuropathy, yes, you brought the muscles together, but the electric wire is gone. So you got to do something to help that as well. That is why sphincteroplasty fails. So we have to now become more smarter and harness our individual strengths and then work towards a patient-centered care. And then only I think we'll be successful in the management. Am I answered your question?
Thank you.
Okay.
Professor Schlumpf has a question.
As a colorectal surgeon, we see following low anterior rectal resection for cancer treatment, see very often the LARS syndrome, the low anterior resection syndrome, which is very boring for the patient, sometimes very tricky to treat. What is your strategy for patients?
It is. It's a great question. It is a very, very challenging issue. So what has happened because of whatever reason, they've lost their reservoir function. You've created an artificial reservoir, and this no longer works like their old rectum. So their sensitivity has changed, and their accommodation has become problematic. So we're struggling with those people. What we have done really is we have done rectal sensory training, and we use an acronym called SAT, which stands for sensory adaptation training. So we place a balloon in the rectum, a large balloon like the compliant Barostat balloon, and then we gently distend this balloon to the level they'll tolerate. Initially, they will tolerate to very low levels. But if you keep doing this over 6 sessions, we can then increase their holding capacity. And that, together with biofeedback, where we teach them to recognize, we've been able to help. I will promise, I'll admit, we have not been able to cure any of them anyway, but we've been able to help them. And I still very distinctly remember a interventional cardiologist who, at the age of 39 or 40, had a rectal cancer. And then he had this procedure done, and he couldn't work because he would be cathing and he would be leaking. And literally, he stopped working for almost 6 years. And then after 4 years, somebody referred him, he came, we helped him with this technique, and after a couple of years, he's been able to get back to work. He now has more. So some of these kind of combined therapies is way to really help them get more capacity, and that's how we've been able to do it.
Thank you very much.
Satish, if I may ask, you're a professor, I'm Müller, Huber-Meyer, this is a very simple name, but I have a very clever wife. And she came up with work about dinosaurs. And the dinosaurs, they have a long tail, and they cannot contract the tail from the head because it's a too long way. So as a Müller simple man, how should I explain it to my patients and to my friend doctors? Is it perhaps possible there is a brain, there is a muscle, but perhaps there is a third brain, not only the belly, but a third brain that you are now get into contact with your neurostimulation, with the magnetic spool, and perhaps this will be this one step forward that we didn't do in the last 30 years. I have hopes, and these 3 days I thought about it, and I believe in your science you do there. I'm very happy, and we will watch you. Am I right to explain it a little bit this way?
I don't know whether you are right, but your wife is right.
I
remember always wives are right.
That I know.
No, I think she's really hit on something important. I agree with you. I mean, there is something more to this anal brain, if you like, for lack of a better word. But I think this neuromodulation is really here to stay. I really think we are just scratching at the tip of this iceberg, and this will be applicable to a number of GI disorders. We now know Parkinson's begins in the gut, and we are just applying it to gastroparesis. A very early study, just published in a small number, showing results, and we are really doing the next study. So I think in IBS, perhaps in fecal incontinence, in gastroparesis, and maybe in some sensory disorders, we will be able to apply this neuromodulation treatment, and perhaps in other disorders in the future. I think this will have a significant role to play.
What you're saying is that all the gastroenterologists, psychiatrists, get a magnet and depression and time.
Exactly, but start with incontinence and then go to depression. But I think yes.
By the way, this is Dr. Mertens, my successor, and to get to the end to this session as well, building bridges. I hope he stays always in contact with you, Satish, because the future is yours. And you can be so lucky in your life to find such a teacher, and I'm amazed to have such much luck. I'm just a simple Müller there in the garden pavilion, and to get to know Professor Rao. This is a dream.
No, you are a great person, Andreas. You underestimate yourself.
No,
but
no,
you've done
no, no, no,
great
I'm
service to your patients. So,
Professor Borovica?
May I ask a last question to challenge your concept? You have said that the lumbar neuropathy might account for 70 to 80% of these problems. Nobody of us probably has dealt with lumbar neuropathies as long. And usually we say the neuropathy comes from the pelvic descensus during birth and the descensus is going on with the aging of women. What is the etiology of the lumbar neuropathy? I know probably you can't say what it is, but is there a clue how we can explain it?
so we don't have a good idea yet. I mean, it is both lumbar and sacral plexus. Remember, I showed you we have 4 sites we're doing it. The neurological injury is multifactorial. Without answering your question directly and not being a politician, but I'm going to tell another story because that kind of helps you understand what I mean by that. Again, so this was a 22-year-old lady. She goes to Hawaii for a family vacation with her family, 2 sisters, mom and dad, and comes back from Hawaii and is constipated. Cannot poop anymore. Has tried every laxative. 6 months have gone, getting high colonics and not well, comes to see us. We do rectal manometry, and yes, she was dyssynergic and she had difficulty in passing the balloon, but she had profound sensory defect. We put up a balloon up to 320 cc's. She barely had any sensation. I said, what's wrong with this 22-year-old young nulliparous lady? Why on earth is she having rectal hyposensitivity? And no megarectum or anything like that. So I went and asked her more questions. I mean, this is obviously after the test. And I said, what happened in the holiday? She said, nothing. I said, well, did you have any injury? Of course, I was almost at the back of my mind, was there some sexual trauma, younger? Absolutely not. But what happened was the last day, they were all 3 sisters were getting up on the diving board and jumping into the swimming pool in this resort. She accidentally fell awkwardly during her jump and twisted her back a little bit. As a youngster, she never paid much attention. She had some niggling backache, came back home. She didn't jump anymore. Her sisters kept on jumping another 20 times, and she forgot about it. But this subtle, what I thought was an avulsion kind of injury in the lumbar region, and we did her TAMS test way back, profound neuropathy. And so that gives you a little feel. Sometimes the injury in some people can be very, very subtle and goes unrecognized. Sometimes it's very profound. They actually tell you they've got back pain and back problems, or they've had back surgeries and so on and so forth. So it is multifactorial, and that I'm not able to define in an individual patient what may be the cause. So I hope that kind of connects you with what I'm saying.
Thank you so much. Unfortunately, the time is running out. I thank you for listening to proctological problems. Now I invite the next speakers. If you have any questions during lunch, feel free to ask. Thank you very much for the attention.
Thank you very much. Thank you.